Good morning, I'm Cho from Malaysia. Today I'm going to share with you how to use point-of-care ultrasound in assessing extubation readiness. So whatever that I'm talking to you today will mainly more on the skill, not so much of evidence. So we're going to discuss about the probes and the 9 steps of Borneo point-of-care ERT, which is extubation readiness testing. In fact, we are trying to assess whether the heart, lung, and diaphragm functions, whether is the patient ready to extubate in terms of these 3 main organs, and also to assess the stomach, whether the patient has full stomach. So seeing is believing is a very important term. And you also have to believe what you are seeing. And you probably have to be seeing with the eager eye. A careful examination will help you to pinpoint the exact what's the problem that occur. Whatever I'm talking to you later on, a lot of time is basically a pattern recognition. These are 3 main important difference probe that we're going to use it day-to-day practice in point-of-care ultrasound. On the left-hand side is a linear probe that we're quite used to when doing line setting. For linear probe per se is high frequency. It's functioning like a small scalpel blade. Whereas is that because it is so fine that you only cut through the superficial structure. And with that, you only can, from this probe wise, you only could see the superficial structure and in a very fine detailed manner. Whereas on the middle part, which is a phase array probe, it's basically commonly used by cardiologists. This probe is very good in terms of looking at the structural movement, especially in terms of the heart. And the image produced is like an X knife, as is shown in the pictures. And thirdly is the curvilinear probe. Curvilinear probe is rather rough probe, but it is a very low frequency. The low frequency enable the probe to see the deeper structure well. So because it's a big chopper, you have a big chopping knife, so you can see quite deep, he can go very deep, but unfortunately the image produced might not be fine detail. So we have to understand the function of each and every ultrasound probe. Hence, from this we have to use it appropriately when we assess the patients. We'll talk about more after this. So we're going to use point-of-care ultrasound to assess whether the patient have good heart function to be ready for extubation, whether the lung is good enough to be extubated, whether the patient have full stomach, and whether the diaphragm, both diaphragm is working well to be extubated. So this is a 9 step of a point-of-care ultrasound for extubation readiness test, and it will follow through later on. So what are these 9 steps referring to, right? So we go one by one. So the first 4 steps is mainly assessing the cardiac function, which is the 1, 2, 3, and 4, followed by the 5th to look at the stomach and the diaphragm and base of the lung. 6 and 7 looking at the both different side of diaphragm and the lower lobe of the lung, and 8 and 9 looking at the anterior lobe of the lung. As we discussed earlier on, the different probes have different function. Hence, if we group it up into 3. So the first 4 assessment of the heart, the best probe will be the phase array, followed by the curvilinear if you do not have a phase array. The subsequent 3, the best probe will be using curvilinear. If you do not have curvilinear, the phase array can be replaced. And the last 2 images have to be best produced by a linear probe or curvilinear probe. And if you do not have 2, the third best will be the phase array. This is a step that we're going to go through. The first one, this is parasternal long axis, followed by a parasternal short axis, papillary muscle view, right? And then you curve down to go to the apex and look outwards to get a 4-chamber view, apical 4-chamber view. Move to the midline, sagittal, and tilt a bit sideways to look at the IVC. Turn the probe around, transversely look at the base of the lung and also the liver and the stomach. Go to the right hypochondrial area, looking at the liver and the right lower lobe. Left hypochondrial area, looking at the spleen and also the left diaphragm, left lower lobe. And go anteriorly towards the right anterior aspect of the lung, okay? And then subsequently go over to the left side, look at the left side of the lung and at the mid parasternal area, and then also the lateral aspect of the lung. Okay, So let's go one by one. The very first step is a parasternal long axis, whereby you're going to assess the heart. And the probe orientation had to be put at the parasternal side, whereby the pointer point towards the around 11 o'clock positions. Okay, so this is what we're going to get, how we're going to assess the view. Okay, so you start from the top part of the upper sternum and you slide downwards. Okay, from the top part, slide downward, making sure that the pointer pointed towards about 10 to 11 o'clock. Okay, slide it down until you're able to get these images. This is what we call a parasternal long axis image, whereby you are assessing the left ventricle, right ventricle, left atrium, and you could see that here is the mitral valve, this is the aortic valve. When you see this is a normal structure that one had to be remember, first you will to see the contractility. So the heart is contracting well, whereby the posterior wall and the septal wall are moving quite closely to each other. And the other important aspect you need to see is that what's the size of the ventricle, okay, in relation to the right and the left, and also size of the atrium. Okay, and looking at the mitral valve as well, the mitral valve is supposed to be a happy mitral valve, whereby it can be open and closed happily without much problem. Alright, so this is a normal structure, parasternal long axis. The way of doing it is to slide down from left parasternal area. So one had to be recognized this what do you call that, normal type of features, and subsequently then we'll see what's the abnormality like later on. Okay, similarly this echocardiogram show you the appropriate orientation, okay, of the heart. And let's look at what is the abnormality that one can detect using this view. Okay, so as you could see, the left hand side is normal echocardiogram parasternal view, and as compared to this side, so we could recognize that what's the abnormality that you have here. You have extra hypoechoic consistency structure around the heart. Okay, when the hypoechoic structure usually represent fluid, so this patient actually have pericardial effusion. And as compared to this echocardiogram image, we compare this side, which is a normal one, and the abnormal one. What you could see that the ventricle did not actually, the heart muscle actually did not pump very well. Okay, and also if you look at the mitral valve, it didn't look so happily. Yeah, it is hardly open and closed. Okay, so this one suggestive of poor cardiac contractility. And sometimes when the patient are under volume, okay, and you could look at it, which is the volume over the left heart, which is very, very small, until the lateral wall and the septal wall are basically kissing each other. Right? They are touching each other. This images suggestive of under volume heart. The step 2 will be a parasternal long axis of the heart. So in this view, similarly, we are looking at the function of the left heart, and also to detect any evidence of pulmonary hypertension. So how to do this? Okay, so the parasternal long axis view, you just turn the probe 90 degree. Yeah, turn the probe 90 degree. Okay, and then after tilt posteriorly, like what we have shown in the picture, until you get a circular donut pattern of the left heart, and also there's a 2 dot which represent the papillary muscle. Okay, so this is what we call a parasternal short axis papillary muscle view. Right, so this is the left heart, which is a donut shape, and then also it's small. You are going to see a small cavity here, which is a right ventricle. Okay, so let's recognize these pictures. So you could see that these pictures. Okay, so this donut actually very, very big as compared to normal one. Okay, and also the wall are a little bit thin. Okay, and it hardly contract as compared to this view. Right, so this will tell you that this child have a very poor cardiac contractility, especially on the left side. The left ventricle is really a donut shape. Right, but now the left ventricle become a D shape. Right, and then at the same time, the small right ventricles have become quite big. Okay, this show you that there's a significant enlargement over the right heart, and then with significant high pressure, that pressing the donut become a D shape. This kind of images suggestive of pulmonary hypertension. The third view is an apical 4-chamber view of the heart. So from the parasternal short axis, you slide down the probe near to the nipple and look outwards. Okay, and then this is the image they're going to see here. So this is the apical 4-chamber view. In fact, you can see all the 4 chambers of the heart. So starting from this side is the left ventricle, okay, and left atrium, right ventricle, right atrium. And this is a ventricular septum, atrial septum. This is mitral valve, this is tricuspid valve. And in normal situation, both heart will be more or less equal in size, okay? We call it a balanced ventricle. Similarly, like the atrium. So if there is some structural abnormality, as shown in these pictures, okay? So when the heart is hardly contract, okay, as you see here, the ventricles did not actually contract very well, and the size of the ventricle did not change very much during the different cardiac phases. And looking at the mitral valve again, it didn't open and close very happily, right? So this image suggests a poorly contract heart. And this image shows also similarly a poorly contract heart, whereby you could see that this size of the heart is remarkably enlarged as compared to earlier scan. So this is suggestive of very chronic type of heart problem with poor contractility. And this view as well, it could show you a significant right heart enlargement. As we discussed earlier on, the left and the right heart size is supposed to be equal in size. As you see now, the right heart is significantly enlarged and right atrium is significantly enlarged. And looking at the septum, is actually deviated to the left side, which suggested that the right heart actually has significant higher pressure and higher volume that pressing the septum to the left side. This image suggests of pulmonary hypertension. After assessing the heart to assess the inferior vena cava. Inferior vena cava, as is shown in these pictures, okay, all right, you go to the midline sagittal and tilt the probe slightly as shown in the picture. And this is the image that you're going to obtain, all right? So in the midline, the lower structure is the inferior vena cava, all right? You see the variations of the inferior vena cava during the phases of respiration. So in a situation, the patient who have a severe volume overload, okay? As you know that in severe overload patients, the inferior vena cava will markedly engorge, all right? So you could see here, this is a inferior vena cava. It's very much engorged and no much of variations, okay? It suggests the patient have significant volume overload. The fifth step will be assessing the stomach, both diaphragm and the base of the lung. The placement of the probe will be a transversely, right? Places at subcostal area, okay? So this is how we do it. You turn the probe the other way around, okay? Subcostally, and slowly fan the probe outwards, okay? All right. And this is the image that you're going to obtain. Whatever they see here is that this structure is actually a liver, okay? This is actually a full stomach, right? And this is a spleen, okay? The lower white color line is actually the diaphragm, right? So in this patient, it actually have significantly full stomach. One need to be aspirate before extubate the patient, right? And in this view as well, you are looking at the both posterior aspect of the diaphragm. And if we observe here, both diaphragm is actually moving, okay? Anything beyond this diaphragm is actually the lung, right? So you should not see anything beyond this line, okay? Whatever they see here is actually artifact, right? And very importantly, this view that you can assess both diaphragm at the same time, which is very important before we extubate the patient. And you could see that movement of this both diaphragm is basically a symmetry. What happened is that in a situation at diaphragm paralysis, as you can observe here, right? So this diaphragm moving quite happily, right? But unfortunately, this right side of the diaphragm did not move very much, okay? So this image tell you that the right diaphragm is not moving, okay? It's diseased, which is paralyzed, okay? At the same time as well, as we discussed earlier on, anything beyond this white line, which is the diaphragm, are the lung, okay? If we should see that the lung become consolidated, like shown in these pictures, okay? And then this is the diaphragm, okay? Diaphragm, you see the diaphragm is moving, and then this is the lung structure, right? If you see that there's consolidated lung, and also there's some effusion, right? And then this is a posterior aspect of the lung diseases, okay? This is very important view, especially the patient is being ventilated. You cannot turn the patient very easily to assess posterior aspect of the lung. And then this is a way that you could peep down to posterior aspect. Step number 6 is assessing the right diaphragm over this side at the right hypochondrial view, right? And then also assessing the right lower lobe of the lung. Okay, this is how it performs. We move the probe towards the right side, putting a right hypochondrial area, looking into the liver, okay, and the right lower lobe of the lung. So this is the image you're going to produce. So this is the liver, okay, this is a kidney, and this is a diaphragm, okay. This view is very good in terms of the assessing the right lower lobe here, okay? And then this is the diaphragm movement as well, right? You will not see anything beyond this because all these are the artifact, okay? You see the white line here, multiple airline here, right? And if you see anything beyond that, it is abnormal. And then this is observe the diaphragm movement, right? As compared to this image, all right? You're going to look at this is the liver, this is the kidney, okay? And then you look at the diaphragm here, okay? The diaphragm movement here as compared to this side, it is very much reduced, right? Very much reduced. It tells you that the diaphragm has some problem. Okay? This aspect of the lung, okay, this lower lobe of the lung is very diseased, okay, with consolidation, with a lot of air collection here, all right? So this is a consolidation of the right lower lobe. Moving the probe towards the left side, we're assessing the left diaphragm and the left lower lobe of the lung. How to do it is to move the probe the other side, okay, right, at the left hypochondrial area. And this is the image they're going to produce, all right? So this is a spleen, this is a kidney, and then this is the left diaphragm, all right? So anything beyond that is actually the lung, okay? You could not see much thing here, is all the artifact, okay? So this is a clear lung view, and then the left diaphragm actually moving quite nicely. So in the disease pattern, okay, you could see that this is the left diaphragm, okay, all right? Yeah, movement is relatively preserved, but you could see that there's some structure here, all right, which suggestive of consolidation of the left lower lobe, right? Lastly is that you're assessing the anterior aspect of the lung, okay? So moving on to the both sides anteriorly, right? You move the probe to go to the right side of the lung, parasternal area, moving upwards, downwards, outwards, downwards. So these are the images they're going to produce, all right, over the lung view, right? And different, as we discussed earlier on, different type of probe produce different kind of image. So this is a linear probe, right? The linear probe go superficial structure, and then the area of scanning is also very little, right? Very limited. This is an example of the lung ultrasound that produced by the linear probe. Okay, you could see that this is a rib, this is a rib, this is a superficial structure. This is actually the pleural line, okay? The movement of pleural line. This is the image of the produced by the linear probe. We're going to discuss more in the afternoon about the lung ultrasound in detail. Okay, if you use the curvilinear probe as shown in these pictures, all right, the probe base is basically much bigger. The area, the coverage of scanning is actually much bigger. You could see more rib here, okay, and then the area of scanning is also much wider. Pulmonary edema is very important features that one had to observe to see whether the patient is whether fluid overload or not. So what's the raining pattern here as reflected in this ultrasound image? So when there's a little drop of water here like this, okay, you could see that if you can observe that there's some drop line here, this is what we call a B line. The B line suggestive of some water, right? So when there are a few drops suggestive of a little water in the lung, which is mild pulmonary edema, when the drop become increased like in these pictures, so there's a multiple drop line, what we call a B line, suggestive of the content of the water in the lung has become increasing, which is a mild pulmonary edema. When the rain become very heavy, right, you could see that multiple B line which is confluence together, right? We call it a confluent B line, okay, and it's like a raining cat and dogs, okay, right? So this is a very important image to want to have to observe, okay, to show that how well is the lung. So in terms of to help you to assess whether this patient is extubatable or not, because by looking at the number of the fluid in the lung. Besides the pulmonary edema, the other important feature is that you want to see what's the consolidation in the lung, right? As consolidation means is that the thing in the lung becomes solidified, right? The lung is originally aerated like here, is well aerated lung. Okay, you should not see any other structure beyond this pleural line. Okay, anything what you see here is actually an artifact. But once you started to see some solid structure, like for example in this view, right, is suggestive of some degree of consolidation. Like as example for this image has small dot here, right? So this is a small consolidation, right? And if the consolidation become bigger, like in these images here, all right? So you need to use a curvilinear probe to assess because the lesion become larger, right? So whenever you use a curvilinear probe, you could see that very much extensive lesions over this particular area. And if the whole lung becomes solidified, all right, like for example, this lobar pneumonia, you can use the ultrasound to probe to assess. Okay, so this is a solidified lung that one had to be very careful before extubating the child. And this is also quite a similar pictures that you could see sometimes, especially when the lung the lung become collapsed, whether due to a mild tube placement or not. So this is the image that you're going to produce, right? As the lung collapse, because the lung become non-aerated and then they are fluid filled. So this is all about the 9 step of point of care ERT. All right. With that, I thank you.